Okay. The modified Allen's test is a test that, depending on the resources that you read, is some of those resources sort of downplay its importance. I'm not allowing you to consider that at this point. I'm asking you to always assess for collateral circulation. This is best practice. Even though some of the specificity of this test is not proven, it makes sense from a best practice perspective. And I have encountered people with inadequate collateral circulation that forces me to look for a different site to puncture. So the modified Allen's test, it's modified based on the historic development of this test, and we'll talk about that in a little bit. So it determines collateral circulation is present, and this test must occur based on our agreement here and as part of our course objectives for RESP 2570. We palpate the radial and ulnar pulse. We do something called blanch the hand, where either we physically squeeze the blood out of the hand or we have the patient make a fist that will successfully decrease the blood in the hand. The hand will take on kind of a whitish gray appearance. It won't look like nice pink perfused tissue. We then maintain occlusion of the radial artery. We simulating that it's been thrombosed. We release the ulnar artery and observe restoration of blood. And that will be the pinking up of the hand, or the flushing of the hand, if you will. And that should take within 5 to 15 seconds. Okay, so be aware that range may change based on your resource. As I look at a compilation of recommendations, 5 to 15 seconds remains appropriate. 15 seconds seems like it takes a long time, right? That's a long time for your hand to pink up. Most people, it occurs within a few seconds. A Doppler ultrasonic flow indicator can also indicate the presence of collateral circulation, and may be used certainly when it's more difficult to palpate. The ulnar artery is a little harder to palpate because of the overlying tendons that sort of lay over top of the vessel and slightly cover it, so it becomes less sensitive to palpation. We need to practice the modified Allen's test, so please make sure you practice with your lab partners in a safe manner, right? So make sure that you're taking the appropriate precautions when doing this. We always clean and wash our hands before we contact the patient and afterwards. This sequential graphic from A, B, C, and D, starting at A, palpating the pulses, radial and ulnar, squeezing those so we obliterate the blood flow going to the hand. We compress those vessels, so we're using the thumb and our index and forefingers primarily as part of maybe the ring finger as well in the obstruction process. Patient, if they can cooperate, they make a fist. The hand goes from, and if you look at the difference from A to C, hand looks whiter, paler in appearance. And I'm not using colored graphics in this case, but it's still apparent with these black and white graphics. And then what we do, note the radial artery thumb side vessel remains obstructed. We release the ulnar vessel to make sure we have ulnar collateral circulation. If we get flushing of the hand, so pinkening up of the hand, it shows a positive indicator that collateral circulation has occurred. That's a big thumbs up, and that is a positive modified Allen's test. Okay, so for our purpose, you must do this. Some RTs do not do it. They are leaning on the side that say that the test isn't specific enough, but I'm not giving you that option. I want you to follow best practice, assess your patient, and certainly my clinical experience shows that you can miss people that don't have collateral circulation. You do a puncture, we know there's a percentage of people that develop a thrombus or vessel obstruction afterwards. Now their hand is going to be ischemic. Okay. And just with these images that are colored, again, supporting what we just talked about, and what we see in this case, upper images on the left hand side. In this case, the clinician is using their thumbs to glued the vessel. I like to use my fingers over the vessel to provide a broader surface area. When you squeeze the patient's arteries, please do not, it should not hurt. Commonly during lab exam, people hurt me. I have to consider that excessive force, and I'm going to dock you some points with that. Should still be comfortable for the patient. Okay, you're not trying to make them tap out. So occlude the radial and ulnar arteries. Hand is blanched, and then the ulnar arteries released, and we should see flushing of the hand. Okay. If there is absent perfusion, the image on the top right shows us a pathologic thrombus as we look, at what's obstructing blood flow. Release of the ulnar artery does not refresh the color of the hand. There's no flushing has occurred. That patient does not have collateral circulation. Okay, so be very aware of that. What we see in the bottom image is the flushing of the hand has occurred post Allen's test. And we see the palm of the hand is nice pink and restored to rather normal color. What we see on the bottom right is partial flushing of the hand. So the radial artery, thumb side, remains occluded, simulating a radial thrombus. Ulnar arteries released, but we only get a fraction of the hand pinking up. This patient has a circulatory anomaly, and I would not puncture that vessel. All right, because if you thrombose the radial artery, then you could essentially have an ischemic or infarcted tissues that are downstream from that point of obstruction. Okay, so be aware, use modified Allen's test in an intelligent fashion, and it is a tool that we should employ. Note, 3 to 5% of the population have absent or minimal ulnar perfusion, according to author of our textbook, Malley. Always perform a modified Allen's test 5 to 15 seconds for flushing, according to Malley. I have had clinical instructors and RT students, comment on that 5 to 15 second range. I used to use a resource that said 10, but let's think about 10 seconds. 10 seconds is the median number between 5 to 15. And so I know St. Paul's had 10 seconds written into their policy, got into a bit of an argument with the then clinical instructor. But when I asked them to provide a source that said 10 was the, definitive value, they couldn't do that because it wasn't, sources weren't included in the development of that policy. So just don't, it's not really open for debate. 5 to 15 seconds is a reasonable time for flushing to occur. And I just caution Procedures Consult, which I like this resource, but it came incredibly expensive to get the students to subscribe to it. It provides up-to-date medical procedures for training physicians primarily, but a lot of those procedures leak over into the respiratory care world. They stated 10 seconds, and so I just ask you to think that that's just the median value. Okay? If the statement in Procedures Consult said, if skin color normalizes in less than 10 seconds, collateral flow is adequate. If normal skin color does not return in 10 seconds, an alternative site should be selected. And I'm expanding that range 5 to 15. And this is a little better image. This comes from Malley, and it shows you the anatomy. Radial artery coming down. Consider this the supinated hand or palm up. In this case, radial artery comes down, bifurcates around the styloid process, which is this bump, bony protrusion at the distal radius, and immediately before that, that bifurcation occurs, and we get the deep palmar arch or branch, and then the superficial palmar arch or branch. The ulnar artery comes in from the other side. So superficial and deep, and terminology arch or branch is what the medical anatomic resources will show. And I've seen both, so I'm mentioning both. Normally, what we've got to think about is around this level here is what is called the volar wrist crease. And so normally, I would say 2 to 3 centimeters from the styloid process, depending on the size of the individual, creates this target range here. I don't like to go right at the point of bifurcation. That's too close to the distal radius, and you will more than likely experience, if you puncture there, you will probably hit bone, and that's very painful for the patient. So landmark the crease 2 to 3 centimeters up the arm. The crease of the wrist generally coordinates with the position of the styloid process. Radial technique. So you should be holding your syringe like a pen, like you're trying to do your most detailed artwork, for example. And I actually like my fingers a little closer to the end of the barrel of the syringe, not way back. Okay, so radial technique, do a modified Allen's test. Patient will be sitting or lying, their wrist slightly extended, not hyperextended, because that can impede blood flow. Clean the site with alcohol, and rather just edit your graphic to support the use of chlorhexidine or a suitable antiseptic agent. Palpate the vessel. Hold the syringe like a pen or pencil. Placing the needle gently on the skin but not advancing. Make sure that you have good sense of palpation. Enter the skin, just bury the bevel of the syringe, of the needle, and I'll show you that in a moment. Bevel needs to be up at 30 to 45 degrees for radial puncture. Advance the needle slowly. A blood flash will occur as blood enters the hub of the needle and the barrel of the syringe. It will autofill. We need the plunger to be higher than the needle in order to allow air to exit, or air could be trapped in the syringe. That can adversely affect our blood gas results and forces us to process air removal from that sample. So with the bevel up at 30 to 45 degrees, advance the quick little skin break to get the bevel under, then advance the needle slowly. Blood will flash and will autofill, as I mentioned. Once complete, we will drape gauze over the wound, withdraw the needle while applying immediate pressure. And we need to apply that under situations of normal coagulation, 5 minutes. Okay, so we'll go over some of the criteria for identifying problems with coagulation shortly. Okay, so tamponading the wound, you're going to be holding it for a minimal 5 minutes. If the patient had adverse coagulation or some other suspected reason that they will bleed excessively, then you need to maintain the tamponade or the pressure over the wound for 10 minutes. No peeking, right? Don't shortchange that time because you could be the reason why a hematoma develops in that patient. Patient position considerations. Patient comfort is very important. Watch the range of motion of a patient that they're capable of. Some people have osteopathic conditions, arthritic changes that will alter their mobility. So be cautious of that. You don't want to be bending them into an uncomfortable position for the sake of getting this diagnostic procedure. You have to adapt your technique. Patients and the RT or student RT must be comfortable, especially when you're learning this. So I encourage you to learn this sitting down, getting into the right position, and we'll identify that during our demos and in the lab. Especially when learning, that's important. Pretty soon you'll be able to do it standing on one foot, leaning across a bed, and as your skills and dexterity improve. Radial artery rules: make yourself and your patient comfortable. Puncturing the vessel in an adult is approximately 2.5 centimeters from the wrist or steloid process, and that positioning is approximately conducive. Is the bevel position, and I'm going to show you a diagram showing you that bevel position, needs to be up. Break the skin, wait, take a breath, ask yourself, am I over top of the artery? Then slowly advance the needle. Move in and out in a single vector. Once you get blood moving, stop advancing because you're basically inside of a lumen of a piece of cooked spaghetti. That would be the comparison to the diameter of the artery at the radial site in a I would say small to medium sized person. Okay, so this graphic shows you that an artery, blood is flowing down to the distal forearm and hand, entering at 30 to 45 degrees is acceptable for radial puncture. We see in the image where we can look into the hand what is occurring. This caregiver is doing something good by staying a couple of centimeters away from the crease of the wrist, and they are coming in at the right angle. They're going in and out in a single vector, and you maintain the palpation of the radial pulse E all the way through the procedure. If you remove your hand from the pulse, you may have a tiny movement in the position of the needle and your blood flow can stop, which means you have to repalpate and then advance or pull back on the needle. If you go right at the crease of the wrist, you'll probably hit bone periosteum. So that's why you need to go up the arm a little bit. Vessel still well stabilized, but it's a bit deeper. So don't be seduced into taking that easy, very superficial puncture, because more than likely you're going to hit their bone. Angle of approach: radial 30 to 45 degrees. Brachial, that occurs up near the antecubital fossa, which is basically at the elbow crease, and slightly medial is in the neighborhood of 45 to 60 degrees. Femoral, we go in at around 90 degrees. There's some range in that angle that can occur and is suggested in some resources. 90 degrees is pretty much the best approach. Bevel is angled upstream, right? And that way it sort of looks like you're scooping the blood with that bevel. Provides the best way to collect the sample. In this case, the image that I'm showing you here, I'm just going to say position wise, yes, that looks like a good place to do a puncture, but remember, it's a medical image, so the guy creating this image may not be a clinician, but what it looks to me is he's coming in kind of from the side. And that's a bad way to go, because if you go through the vessel, remember the vessel's the diameter of a piece of cooked spaghetti, you can go through and hit the flexor carpi radialis tendon that's immediately medial to that artery. Okay, that would be the proximal position of the flexor carpi radialis tendon. So I don't want you to come in from the side. I want you to come in over top, like we see in the image. Blood is coming down. In this case, this guy's opting for a 4 and ring finger palpation. He probably used his index finger but pulled it away, and then he's puncturing immediately in front of his finger. The needle gets close to the caregiver's finger. Here we're seeing the flash of blood into the syringe. Blood will immediately pulse in, fill the hub, and then fill the syringe. Okay, he's keeping the angle, so remember the plunger's vented. Blood, as it fills, will force the air out, and air comes out the back of the plunger, plunger seal, right, and leaks out. Okay, but they won't allow the blood to leave. It just allows the air to leave. Landmark near the steloid process, and then move up the arm, superficial, relatively well stabilized, and we want to avoid bone contact. Okay. In this case, another example of what needs to occur. Before the needle comes out, we drape gauze over the site and we withdraw the needle and immediately apply pressure. This suggests 5 minutes, but that assumes normal coagulation process. In the image on the upper right side, simultaneously, while providing tamponading of the patient's wound, in this case it looks like they're using 4x4 gauze, it's just bigger gauze, that's okay too, then they are using a hard surface to close the cap of the needle. I've shown you a variety of needle syringe combinations using these safety caps. Most often we use a 3cc syringe, it's blood gas syringe, vented, plunger, and lyophilized heparin or other heparin, little heparin tablets basically in the hub of the needle and the syringe that will inhibit coagulation. Okay, no peeking under the gauze until your duration of tamponade is expired. Okay. Looking at this graphic comes from a anatomy resource. This is placed into RESP 2570 resources that can be accessed from that Moodle tab under sampling. I need you to memorize the names of all the anatomic structures that are included in this package. Okay, there's no ands, ifs, or buts. You need to recognize it. You'll need to correctly select answers or write down the answer on tests. Okay, so looking at the supinated hand, skin removed, and the deeper structures are visualized here. Flexor carpi radialis tendon, we can see it if we follow the blue line. Radial artery is seen there, and approximately at the point where the best puncture technique should be acquired. Brachioradialis tendon is lateral to that. Remember, in the supinated hand, lateral is on the outside. Flexor digitorum superficialis is the tendon that slightly overlays the ulnar artery, shows the ulnar artery, and it also shows the flexor carpi ulnaris tendon. Those two tendons kind of shield your access to that ulnar artery, and so the ulnar sampling is kind of discouraged based on that. You know, you're more likely to hit a tendon if you use that site. Some RTs brag that they have used the ulnar artery. I sure hope they checked for collateral circulation, and it goes against most policies and procedures, so you put yourself at a bit of a practice risk by doing that, and maybe put the patient at some risk. This slide outlines some of the features and functions of the tendons. So brachioradialis flexes the arm at the elbow and brings the forearm into a mid-prone position. That's the function of that tendon. Flexor carpi radialis flexes and abducts the wrist. Abduct is towards the lateral plane. Flexor digitorum superficialis flexes the proximal phalangeal joints, so your fingers, and flexor carpi ulnaris flexes and adducts the wrist. So note, abduction is towards the lateral plane, adduct is towards the medial plane. Just a couple of additional graphics that are added into the PowerPoint, but they are not in that anatomy graphics package that I've asked you to memorize. And this just shows you the insertion of and origins of various muscles and their tendons. So brachioradialis in that more lateral position, and this shows the flexor carpi radialis and flexor carpi ulnaris tendons. The median nerve innervates the muscles of the forearm and hands, sensory information from the skin of the thumb, index, and middle finger. The ulnar nerve supplies sensory and motor innervation to the hand and forearm. The median antebrachial cutaneous nerve provides motor functions, controls flexor muscles in the forearm, and thenar, and those are muscle groups in the palm of the hand, and sensory functions of the inferior forearm and the lateral palm and fingers. Nerve roots that we see here. So the major nerve supplying the hand, the median nerve, if we look in comparing its position to the radial artery in this graphic that appears in Mali, median nerve here, radial artery here. That median nerve is a long ways away from where we should be doing our site, our punctures. It's somewhere around there, right? So what we have to be aware of is that if you come in a lateral approach, you could go through the artery and hit that nerve. That's why I ask you to align yourself, come in, be more superficial, don't come in from a lateral approach, right? It's a failed approach to this. Yes, skilled hands could get it, but it's a bad practice, and you shouldn't be teaching or utilizing that approach. Ulnar artery is actually quite close to the ulnar nerve, so very proximal, which is another reason why I say don't use the ulnar artery, even if it's tempting you because of its proximity to the nerve. Your policies and procedures and protocols are designed to advise you that the radial artery is the puncture site, not the ulnar artery. This is just another graphic showing some additional anatomic view showing the bifurcation of the radial artery to the superficial palmar branch, and that may also be called superficial palmar arch. You can use those terms interchangeably. Okay, and it shows that superficial branch supplying blood, and also the connection to the ulnar artery that's on the non-thumb side, on the pinky side of the supinated hand. This graphic shows a cross section near the distal forearm proximal to where you may be doing a puncture. And I'm using this graphic. It's an older graphic that I scanned a while ago, but I just can't really find one that shows me what I want you to see. So I'm going to stick with this graphic. Flexor carpi radialis, follow this purple line, and we get to the flexor carpi radialis. It's the radial artery sandwiched between the brachioradialis and the flexor carpi radialis, and in the supinated hand the brachioradialis is lateral. The flexor carpi radialis is more medial. Note the median nerve position. And this is again why we do not come through the from a lateral to medial approach with the vector that we're advancing our needle into the tissues. Bones of the distal form, wrist and hand, just fairly straightforward. We see radius and ulna. Steloid process of the radius is well illustrated in here, and that's the bump on your distal radius. That starts as a landmark. Move up the arm a little bit where the vessel is a little bit deeper, and but still well isolated, but away from bone periosteum. If you go right at the steloid, you're kind of risking hitting bone periosteum. Ulna is in the supinated hand, is on the medial side. Scaphoid is one of our carpals that is sort of next in line, and that it has some significance why I've listed it here. Metacarpals and phalanges are also noted in this image. So what I want you to be aware of is that off of the radial artery, what we see is a blood supply that is supplying via the superficial palmar branch. It is supplying the scaphoid. Okay, the scaphoid is particularly delicate. There's because fractures of the scaphoid through trauma may interfere with blood supply, and a bisection in that structure can lead to avascular necrosis because of the inadequate blood supply to that bone. So hence hand distal extremity fractures need to be closely assessed. Assessment for pain, some pain on mobilization, and just by the mechanics of the trauma, the scaphoid fracture needs to be ruled in or ruled out as part of the assessment. Hence, close scrutiny over radiology associated with this. So if you think somebody has had, distal extremity injury, don't puncture that site. Use a different site, because we still may need blood gas analysis in that patient. This fracture is seen in boxers. It's seen in, skateboarders, people falling down, we need to take this fairly seriously. I appreciate it because I've fractured my scaphoid in the past and needed this scrutiny. What often happens is initial radiography will occur, and then a short period of time afterwards, within the next week, because sometimes these fractures don't materialize and aren't visible radiologically for a period of time after the injury. At VGH, where I worked, we had the hand clinic there, and we had specialized plastic surgeons that would be involved in scrutiny, oversight, care, and procedures designed to, help people get their hand function back. And this injury, scaphoid fracture, has retired a number of famous athletes. For example, Gordie Howe, a famous hockey player, ended up. This was one of probably multiple criteria that sent him into retirement. The brachial artery. Now, please be aware that at certain hospital sites, they may or may not endorse the use of the brachial artery for sampling of arterial blood. And that is because the vessel site where the sampling would occur is quite close to major nerve roots. There has been documentation of nerve injury associated with brachial artery puncture. So be sure to check your policy and procedures for viability of using this site. The brachial artery is generally considered when unsuitable radial artery sampling has been assessed. Some resources that I've encountered that have been directed towards RTs who do brachial puncture have suggested that there is not collateral circulation. Some investigation of human anatomy makes me articulate to you that there is collateral circulation that occurs via the ulnar recurrent and inferior ulnar collateral vessels that are identified in the image that is included on this slide. So I would argue that there is collateral circulation. The sort of hazards and complications that are occasionally articulated are risk of nerve injury and absence of collateral circulation. I would suggest that it's more likely that the risk of nerve injury is the major consideration to not using this site for sampling. Regardless, if radial artery sampling is contraindicated, then it may, if allowed, present a viable option. It tends to be the second and sometimes third choice due to that proximity of the median nerve and large veins that reside in the area that is being targeted for sampling. Remember, an optimal sampling site is where the vessel is most superficial and well stabilized. Not to say that this vessel is either of those two. It tends to be a deeper acquisition of for the sample, deeper penetration by the needle, and a little more risky as far as proximal anatomy. The location of the vessel is the medial anterior aspect of the antecubital fossa near the biceps insertion. Brachial artery. There is relatively minimal vessel support by fascia and bone. It's more prone to hematoma, and that's due to inconspicuous hemorrhage that can't be detected for a period of time after the puncture. Inability to adequately tamponade or short tamponade times that are inadequate to promote hemostasis can be the etiology for the extravasation of blood and the hematoma formation. Remember, a really bad hematoma is a space-occupying lesion that can compress vessels and nerves in the area. More difficult to palpate and stabilize is one reason why I may ask you to forego this site if you don't have some prior experience and good mentoring on the approach. Close proximity to major nerve roots, I've already mentioned, is a reason why some hazards may be more evident with brachial puncture. There is greater potential for nerve injury, and there is some suggestion that those injuries may be permanent. This has led to medical legal implications in people who've developed some nerve problems after brachial puncture. Avoid this site in children and infants, and avoid this site if scarring or some pathology exists. So irregularities to the skin, abnormal tissue, the lesions, burns, items like that that are detected in the pre-puncture assessment require that you choose an alternative site. Just this graphic shows the skin removed from the anatomy, a little bit pixelated at this magnification. The arm's extended, hand is supinated, detecting a pulse in the antecubital fossa, and then sliding your palpating finger around to the point of the biceps insertion on the medial aspect of the antecubital fossa is probably the best suggestion for landmarking and puncture. It's not immediately at the elbow crease. Okay, this graphic shows relatively good exposure of the vessel in a reasonable resolution. Note the biceps median nerve is the nerve in question that is quite proximal to the location where puncture would occur. Median cutaneous nerve is a little more medial to that position and tends to be a little farther away. Brachial artery is well exposed at the antecubital fossa near the biceps insertion, and I would say the medial aspect of the antecubital fossa. The bifurcation of the radial and ulnar arteries is also shown a little farther down the arm in that antecubital fossa, and has been outlined in yellow. So just for utilizing this graphic, puncture should occur in that window of exposure where it is labeled brachial artery. The yellow ring on this image shows the bifurcation of radial and ulnar arteries and or the location of the ACF or antecubital fossa. Another graphic showing nerve, artery, the brachial artery, and veins that are in proximity. And so you can see in the red circle that exposure of the brachial artery, proximity to the median nerve, and also to the blood vessels, the venous circulation that is in that area. The graphic on the right side of this image, these are from Grey's Anatomy, and I don't mean the sappy nighttime soap opera, but rather the anatomy resource. Red circle shows window of exposure as well as proximity to the median nerve. Brachial technique: extend the arm at the elbow, palm up, supinated, palpate the vessel, trace the vector, puncture slightly above the elbow crease at a 45 to 60 degree angle. Femoral artery. So this is our third, maybe our second choice if brachial artery sampling is not permitted at your site, or if it's contraindicated for another reason. No collateral circulation, and so patency is vital. It is deep, it's close proximity to the femoral nerve and femoral vein. Proximal anatomy, so anatomy at and around the site where you're going to puncture, we can remember this from a lateral, so the outside moving in, lateral to medial approach, nav, nerve, artery, vein, in that order. So Most lateral is the nerve. In the middle of those structures is the artery, then the vein. You're at an increased risk with less than cautious sampling technique of acquiring a venous sample. Femoral artery is palpated below the inguinal ligament. Be aware of proximal structures, nerve, artery, vein, as I've mentioned. Avoid unless the patient is hypotensive with a low perfusion state. So this is a site where we may, be forced to use femoral sampling if a patient has a lower systolic blood pressure and the other sites are hard to palpate. It's contraindicated where there has been vascular modification, such as fem-pop bypass surgery or other evidence of surgery or lesions. There is risk of inconspicuous hemorrhage, and in my experience, it's usually associated with people not tamponading the wound long enough, and also that it's a deep or sampling technique, and so it may be more prone to bleeding. That bleeding can accumulate in the post-puncture time period. It's a deep location, so we tend to use a longer needle, and we tend to come in at a higher angle, like closer to 90 degrees. Liberation of atherosclerotic plaques may occur in these situations because if that vessel does have pathologic changes occurring in it, then some of those plaques have been implicated in being liberated into circulation, where they can, cause an obstructive event. And just reminding you of the organization from a lateral to a medial approach. And as I just collect my pen here, so lateral on this side, medial on this side, palpation of the inguinal ligament. The femoral nerve is most lateral, the artery is central, and the femoral vein is more medial. So following the inguinal ligament down and in this femoral crease, vessel isolation techniques, there's a variety of them, generally trying to palpate, the more superior aspect of the artery, palpate with one finger, like the forefinger, palpate the femoral artery also with the index finger, and the space in between those two fingers, if you have a pulse on both of them, is a good target area. You'll encounter a variety of isolation techniques that will be supported by your clinical instructor and preceptors that are supporting your clinical experiences. Approximately a 90-degree approach is most often recommended as opposed to an angled approach. When we use an angled approach, the needle travels farther through more tissue before it hits the artery. That's good for when it's a radial artery that's really superficial and you're really only dealing with the thickness of the skin before you land in the artery. In this case, because you have to go in deeper, then a 90-degree straight up and down approach is favored. Femoral puncture should be distal, so down the leg from that inguinal ligament and femoral crease. Puncture where the pulse is most evident, and that angle, again, just as a reminder, various vessel isolation techniques I've articulated will be covered, and your experience will help you to choose the right method. Femoral artery puncture rather, it can be associated with serious complications. Hemorrhage can be significant and inconspicuous, so you might not know it's happening, even though it's happening, and there could be a lot of blood extravasate into the area. Atherosclerotic plaque liberation, I've mentioned, and those leg vessels can be subject to the disease segments in vulnerable populations. Elevated infection risk, it based on its proximity to structures. There may be poor hygiene in that area, and certain patients, and so comprehensive cleaning of that site needs to occur. Maybe just a clinical recommendation with a little more vigor than with a brachial or radial site. Hypotensive patient with decreased peripheral perfusion is usually why we select this site. Sample handling, we'll look at this more when we look at blood gas analysis errors. Remember, when you're acquiring your blood sample, you need to make your needle safe. Make sure that the needle cover is locked in place. Needle needs to be prevented from being exposed because it's to somebody getting a Sharps injury. It has been in a patient, so blood-body fluid considerations and risks are associated with unsafely managed needles and other Sharps. Needle lock devices are certainly the preferred method as a safety apparatus to be included with your equipment needs. Remove the needle once the tamponading is complete and your patient is safe and no risk of hematoma can be detected. Remove the needle from the syringe, dispose of the needle into a Sharps container, expel air through the vent cap or gauze, or with gauze, and there's commercial caps that will allow air to be evacuated, and they should be replaced with the traditional non-vented caps prior to transport to the lab. If air remains in the syringe, it's best to use devices. One commercial device is called Filter Pro, and it's a little cap that goes on. It has a porous material in the cap that allows air to exit but will not allow the blood to exit. Mix the sample by inverting or gently rolling it, and that mixes a lyophilized heparin and extends the useful life of that sample before a coagulation could occur. Label, name, ID, date, time, FiO2 and device. Patient temperature is sometimes recorded or asked for at time of collection. Respiratory frequency or positive pressure ventilation settings. Why are we doing the sample? Is it to check an FiO2 change, check a ventilation change, or initiation of mechanical ventilation? Often that is articulated in the documentation. Store and transport on ice only when there's prolonged delay over 30 minutes. And I'll talk more about why that's important. There's some, it's really consistency of how our entire department manages blood gases that prevent errors associated with the pre-analytical phase of blood gas analysis that would include the sample collection and handling. Document puncture site, location, number of attempts, site appearance, whether a modified Allen's test was performed, and that we have assessed for return of pulsatile flow. That's an assessment where we repalpate the site to make sure that there is a pulse distal to the puncture site that would be somewhat supportive that a pathologic thrombus hasn't occurred. Label information, order was verified or rationale for the blood gas, sampling, date, time, FiO2, device, patient temp, frequency, or other pertinent ventilatory status, oxygenation status, or positive pressure ventilation settings. Here's an example of a slide that just shows some documentation. It says RESP services, ABG requested for desaturation events. Patient was on room air oximetry and showed 88%. Puncture was performed probably for the low oxygenation reported by pulse oximetry and it was performed on the right radial artery post positive Allen's test. ABG sample was acquired per first attempt, so no multiple attempts were taken. Site held 5 minutes, no complications noted, and obviously no reason, was identified that we needed to start with 10 minutes like a coagulopathy or that the patient was on anticoagulants. Distal pulse was detected post-procedure, so good follow-up assessment. Patient placed on 40% aerosol face mask, and that was to treat the hypoxemia that was detected with the lower SAT. SpO2 rose to 93%, which is congruent to oxygen therapy policies that usually articulate a keep SAT greater than or equal to 92%. And if patients not showing stability with their oxygenation, O2 therapy may be employed. Arterial blood gas and co-oximetry results are pending at the point that this fantastic RT wrote in the notes, and so once they acquire the lab results, then they'll address that. May have to rechart their findings and also determine what follow-up care needs to occur. A few URLs showing aeroradial artery catheterization that you can refer to. Aeroradial artery catheterization is the Seldinger kit that's commonly employed by Cook Medical. The New England Journal of Medicine has some videos. They're a little bit older, but they follow through the steps and provide you with some useful information. There's also ultrasound guidance for radial artery catheter placement that can be explored, but we won't be starting that in the lab until everybody gets through puncture, cannulation, and hemodynamic equipment build and sampling. Arterial catheterization video resources include arterial line placement, the Aero integrated Seldinger insertion. These just offer some additional resources for you. And again, ultrasound guided radial artery catheter insertion. That's a different kit. It's called via AngioCath, not an Aero kit. Here we see ultrasound guided placement where they've got their ultrasound transducer carefully packaged up because they're likely using it on multiple different patients, and so they would have to put clean covering on that. And in the case we have what's called transverse orientation, the ultrasound transducer being placed in a transverse orientation. This little dot that we see here, or white image, is the catheter going into the artery, or the needle catheter combination. A longitudinal orientation, if you look, transverse is kind of across the wrist this way, right, or the distal forearm, and longitudinal is along the path of the artery. And what we can see, this is the catheter being inserted, the needle catheter combination. Okay, that is being detected along the length with that longitudinal orientation. I'll show you both techniques in the lab. And there's the New England Journal of Medicine showing their approach to this that you can access online. And just remember what's occurring is the transducer sends the ultrasonic signal in. The echogenetic properties of the tissues helps to provide us with the image. And in this case, what we see here is in this transverse section, we see the single dot in the lumen of the radial artery in this case, and that's showing us that the needle went in. It's not showing us that the needle actually in this case went right through the artery based on that image. And so there are special features and catheters and needles that can be combinations that can be purchased that have features that are designed to be more echogenic. And what this image shows is the feature of these rings, and they're raised or depression on the surface of the needle that you see in the image, or these little sort of diamond shaped indentations increase the echogenicity of these needle catheter combinations that allows for more visualization. So these are commercial products. Generally, they're quite expensive, not necessary for things like radial artery catheterization, but they do exist. This is a URL that refers you to a video from Harvard on transducers, and but I'm providing you with adequate resources for understanding the componentry of hemodynamic monitoring systems, but this will provide a video resource should you choose to